Hi, welcome to RheumNow's Rheumatology Roundup. This is a live session where we present highlights of the 2020 virtual meeting of the American College of Rheumatology. I'm Artie Kavanaugh, University of California, San Diego.
Hey, I'm Jack Cush from UT Southwestern Medical School in Dallas, Texas, and we're coming to you live from the dining room, and we promise we are wearing pants. This program will be a discussion of the abstracts and presentations of interest at this year's meeting. Note that the abstracts were chosen without influence from any society, industry, or people at the Saturday afternoon tweet up that Artie was at, I think. Abstracts were chosen on the basis of innovation and impact on practice. This live session represents our uncensored views on these topics. Reproduction of this award-winning, crowdsourced, and live production without prior authorization from United Healthcare is prohibited. Artie, start us off.
All right, well, the ACR meeting's huge. I think they had 16,000 people watching online. I think they had 111 countries were represented, they said. So a gazillion terabytes of information was shared. And I think they did a very nice job. I think all of us wish we were able to be there, but still, we got a lot of interesting information. So I'm going to start with an abstract that I think highlights a couple points. This is abstract 818, and this is from Spain, Dr. Roberto, and this is efficacy and safety of switching JAK inhibitors in rheumatoid arthritis. So this is more of an observational study. It was anecdotal, to be sure. What they did is they looked in their clinic, and they have both the availability to use tofacitinib and to use baricitinib. And they had a group of patients who had started one, and about half the patients, they had 31 total, had started the other. And what they did is to see what happens when people switched. So they switched for various reasons, because they weren't doing as well, because they had some tolerability issue. Interesting though, they had pretty good survival on the second JAK inhibitor. So they had high disease activity going in. It was a moderate disease, a DAS of 5.3. And they got much lower when they got to the second JAK inhibitor. Most of the people that stopped it there was a small number of people who did stop it, with the response rate for the second JAK inhibitor being similar to that of the first. So these molecules are similar, but they're different. The agencies, I think, consider them in some ways to be a class, but I think this is a very practical issue that is important for treating rheumatologists to know that if my patient got one JAK inhibitor, and now there are, of course, different numbers available in different countries. We have 3 available to us. They'll probably have more. Can you switch from one? Now, it's not the strongest data, but I think it was an important clinical message.
This mirrors actually my very limited experience in JAK switching in my clinic, but I think it's an important concept to prove in a study fashion, because, rooms are certainly familiar with TNF switching, 1, 2, 3, and most are moving on by after 2, some after 3. But then we're faced with a whole bunch of new classes of drugs, IL-17 inhibitors, IL-6 inhibitors, now the JAKs, of which we have multiple. And the question is, are you one and done there, or do you move on to another one if you like that, or your patient likes that kind of therapy? I think it's important. Actually, the ACR guidelines seems like one of the recommendations they had, if you had a patient is on a biologic or targeted synthetic and you need to switch, they're suggesting that you go to another class. And they didn't seem to address in what they presented in limited fashion today, the idea of switching within the same class as opposed to changing to another MOA. So I think it's reasonable to make these switches, but then again, how often and how soon? I think the rule probably still stands and didn't seem to apply in this study, but if you are primary non-responder to a class, it wouldn't make sense to stick with that class by switching within the class.
Well, it wasn't a study per se, so it's observational, and there's a lot more questions that could have been asked about it. But I think it's the first information of any sort that says what people are starting to say is like, yeah, you can do it, and maybe the second one will work.
All right, so my first one's going to be the FAST study. This was actually presented today. It's a really interesting study. It is a European regulatory requirement for this study to be done. It's a study of febuxostat in patients with gout and gout patients who are not controlled. The history on this is that febuxostat, as you know, was approved a number of years ago after it had its problems in drug development with cardiovascular signal, more cardiovascular events with febuxostat than with the other urate lowering therapy, allopurinol. They did a confirmed study which proved that it was no different than allopurinol. In fact, there was actually more cardiovascular events with allopurinol in the confirmed study. And then last year we had the CARE study, a very large study that showed again more cardiovascular signal with febuxostat. That led to a boxed warning saying that you shouldn't use febuxostat first. You should use it second, and only people who don't have a big cardiovascular risk. But there's this FAST study that was a regulatory commitment by the EMA. It's a study that was done in the UK, Sweden, and Denmark. And they enrolled patients, an open label study of people on allopurinol not doing well, who either stayed on allopurinol or went on febuxostat in varying doses, but the mean dose in the study was around 80 milligrams per day. And they enrolled over 6,000 patients, treated them for 5 years, and the withdrawal rates were low, 5.5 to 6.2%. The flare rates were about 1,000 per arm, or about 17 per thousand per year, or something like that. In the end, when you compared the cardiovascular outcomes or death rates in those treated with febuxostat or the comparator drug allopurinol, they were exactly the same. So this was, again, very different than what was seen at the CARE study. And the question is, what will happen with this kind of data going forward?
I think it's a nice study to talk about. As you said, the people with gout are at risk for cardiovascular disease. So if you want hard endpoints, and I guess death is a pretty hard endpoint, or a cardiovascular event, it's certainly an enriched population. What they did in this study was also nice in that one of the questions is the control of uric acid a factor? And the other studies, febuxostat looked worse, but it also was more efficient for the gout. It had more flares, it had lower uric acid. Here, it was a treat to target approach to it, and therefore they were pretty similar in how they achieved the uric acid. But it highlights just some of the complexity of doing these kind of studies. They had a nice design that everybody ran in on allopurinol, then they went to febuxostat or stayed on allopurinol. Well, of course, that is a biased in a way against febuxostat because the people who were intolerant of allopurinol would have left already before the run-in. So they did have a few more people leave, a few more percentage-wise, but it was a huge study. So there were a number of patients who left with febuxostat, and how does that impact the data? So I think it introduces some issues. The dose is another issue. The dose they used with I think you asked, and it was about 80 milligrams because they're allowed to use the 120 in Europe. So they did have people on that higher dose. I think it's good information, and I think this goes to the patient level. So. All right, before I get to my next one, somebody chatted and asked, the first one I talked about, the switching JAK inhibitors, that was 818. The next one that I'm going to do, and I'm going to, when Jack and I do these, we always like to highlight some basic science work. And there was a session that was presented, which I thought was really interesting. The abstract I'd like to talk about was 1443. And this dealt with the checkpoint inhibitors. And checkpoint inhibitors are something, boy, I think we're all going to have to learn a lot more about these. They had a couple of review sessions on it that were good. But this was a basic science analysis where they took 11 patients who had the checkpoint inhibitor therapy. 9 of them were PD-1 inhibitors, which is the most common, and also more likely a cause of inflammatory arthritis than the CTLA-4 based therapies. So they took patients with inflammatory arthritis, and their hypothesis was that maybe this arthritis would look more like rheumatoid arthritis from a histopathologic standpoint. Maybe it would look more like spondyloarthritis. Clinically, maybe I think we see both. We see oligoarticular. I think because the last few people I've seen have been oligoarticular, but I know we have polyarticular patients as well. Anyway, they did flow and RNA sequencing of individual cells to get transcriptomics. So they looked at the cells and then looked at the expression. Interestingly, they found a unique population of cells. There was a CD8 subset, which represented 80% of the T cells. It was CD38 high, CD127 negative, and PD1 positive. They did have an increased expression of cytotoxic genes, and they did have a interferon signature. They did, which you wouldn't think of as being, I mean, happens in RA, happens in PSA. You think of it being associated with lupus, but they found that in the overtranscription of genes downstream from the type 1 interferon. So I think this was fascinating. First of all, the ability to do the work where they can look at individual cell types, which are, even though if they're the same type of cell, they might have differences at the expression level. They found the population. Maybe this will translate into something we can use therapeutically. We have guidelines on immune checkpoint inhibitor arthritis, but not a lot of data. So maybe this is promising.
Yeah, there's certainly a lot at this meeting about checkpoint inhibitors and stuff that affects us, and it's a growing concern for rheumatologists because most of us are seeing this. And short of using steroids, the next step is really concerning, and then other steps about like how long we're going to have to treat them for, and when do we, how are we going to communicate with the oncologist about when they can resume their checkpoint therapies and whatnot. It still seems to be a fair amount of push pull, but thank God we have research like this. Again, the authors didn't take this to the next step and postulate on how this could be used therapeutically, did they?
No, and it was just a small number of people, but I think this finding really did surprise them. And maybe we should be thinking more of alternative therapies. As you say, one of the problems is anything we're going to use for inflammatory arthritis, you sure don't want to interfere with the ability to kill the tumor. That's why they're on the checkpoint inhibitor in the first place. In the clinic, it's tough, isn't it? Because they're on these for the long haul, the checkpoint inhibitors.
Yeah.
There's no sometimes you'll see, well, maybe if you're still doing well next year, we'll think about stopping it, but they're on them for the long haul. So this is something we certainly need more information.
So I want to talk about vaccination, and specifically vaccination in patients who are receiving tofacitinib. So there were two abstracts that were presented, late breaking 4, LO4, presented by Kevin Winthrop, and then a Shingrix vaccination in tofa that was 1997. Kevin presented this data on the drug development program with tofacitinib and 21 trials, and at a low number of patients who received the influenza vaccine. And the point of this was, could they get the influenza vaccine? Was there any real issue in there? And the bottom line was there was not. There was no greater, and of course they had patients who were on placebo in their trials and on methotrexate and on adalimumab and also on tofacitinib. And the numbers of, actual influenza events or even worse, hospitalizations or serious events, those were like less than 1 or 1.5% across the board. The bottom line was it looked pretty good. So that's good news for you, especially now as we're getting into the flu season and worrying about when we're gonna get the COVID vaccine. Can you do this in your patients on tofacitinib? The answer is yes. But wait, there's this other abstract that was presented by Kalmark from Sweden, and it was a study to look at the sort of the immunogenic potential of the new shingles subunit vaccine, the one that's on the market now, the Shingrix. And in that study, they studied 40 patients, and they had a bunch of controls, and they showed that the controls had a good antibody response, and the tofacitinib patients also had a good antibody response, and they had mild to moderate symptoms, no big deal. But the caveat worth mentioning here is that 25% of patients on tofacitinib did not have an antibody response, which, I'm sending all my patients that are going on the a JAK inhibitor to receive the Shingrix vaccine. And even ones who are not old enough to get it, I'm trying to implore them to get it, because this class of drugs does impart a 3 to 4 to 5-fold higher risk of shingles. And if you can avoid it with a 95% effective drug, why not? But this says that maybe like methotrexate, for people who are on, and it's maybe because this is not really what the intention of the study was, but maybe like methotrexate for people who you're going to give Shingrix to, maybe they should suspend the use of tofacitinib for, I don't know, a week or two. What would you do with this data?
Well, the problem is we don't know what they mean. So presumably your cell-mediated immunity is more important for the control of viral infection, such as zoster. This is a nice surrogate looking at the antibody production, but we don't know as much about what that means. It may be possible that they have perfectly good ability to control it, control the zoster, or it could be that they need a booster. The 0 and then 2 to 6 months later, very reasonable. And certainly that was seemed to be quite efficient in the general population, but maybe it's not in these people. We don't have a great readout, because we don't care about antibodies. We care about cases of zoster. So oh, there's Jeff Curtis, who writes in and says, Kevin and Winthrop and I are starting a larger Shingrix trial in RA next year. Awesome. Well, thank you, Jeff. And yeah, I mean, we want to see events. That's what we really want to know. That's one of the difficulties. Even I think in infections where it's the antibodies are more reliable in terms of to predict, you still want events. You're preventing the disease. That's what you want to see.
Yeah, so I also want to give, I saw Jeff's tweet about this and I said, oh, I got to go look at that abstract. So thank you, Dr. Curtis, for steering me towards something kind of important. Artie, what's your next one?
Well, before I go to the next one, let me add, there was a comment on the checkpoint inhibitor commenting. Could you comment on the TNF and IL-6 inhibition? I've had more experience with the TNF inhibition, and I think that I think it's my level of comfort and the oncologist level of comfort with what they're okay with me doing. I haven't really used IL-6 inhibition much, but it makes perfect sense. The trouble is, we're just all dealing with anecdotes, and I don't, I go with what I had more experience with, and I can't say that that's the right way to go. Jack, do you have a preference? Or
steroids, TNF inhibitors, IL-6 is certainly possible. I think you stay clear of abatacept because of CTLA-4. But other than that, that's been my general rule. I've only had one patient who clearly had this and one who maybe had this. So I haven't not seen that, not as many as like Lenny or David Liu or some of the other people I know have seen a lot of this.
Yeah, I think we're all going to see many more of them, though.
Right.
So my next is 1484, which isn't very sexy. I mean, not the number, but the study.
So time to go to the refrigerator, folks.
Because it's a negative study. But I think sometimes negative studies give us good information, just like positive studies could. This is efficacy of tocilizumab in patients with hand osteoarthritis. So, boy, there's been, every year it seems like there's a study, or every other year there's a study on pretty much all the drugs that we have, and pretty equivocal data, and then differences in the study design. Mostly they're negative, though. There was a review in the Rheumatology Oxford 2 years ago and looked at this, and maybe there was a hint of a positive signal for hydroxychloroquine. But I think this is an important issue. I think when we see osteoarthritis patients, boy, it gets harder and harder to say we got nothing. But if you come back, if you get RA, because I got 20 therapies, and if you have PSA, I got 15, and if you have lupus, I have 6. So this was, I think a nicely designed study, not so big, 104 patients, and 80 of the patients completed the study. They didn't find a difference. So the primary outcome was the visual analog scale for pain, which had to be above 40 at the start. The delta was minus 7.9 in the tocilizumab group and minus 9.9 in the placebo. So the p-value, as you can imagine, is 0.7. So absolutely no difference about that. Also, no difference in the secondary outcomes. And as you would expect, a little bit more of a signal with adverse events in the treatment group. So still a big unmet need in osteoarthritis, particularly the inflammatory kind. I think, what do? We sort of treat them with the agents that we have for rheumatoid arthritis. We treat them methotrexate. We give them hydroxychloroquine, at least until this year, when I had to. I like to use hydroxychloroquine for inflammatory hand OA, but all of them had to develop rheumatoid arthritis in the chart so that I could get the drug for them because they weren't getting it this summer.
Or
But
COVID.
COVID, it was COVID related related arthritis, CRA. Um, but it was a negative study, nicely done study, negative study. And especially when you think about the tolerability issues, that of course weighs in our decision to use any treatment.
So the therapeutic pessimist likes to talk about all the drugs that have failed in scleroderma. They should change that to all the drugs that have failed in osteoarthritis, especially of the hand, and doesn't even have to be inflammatory OA. All of our DMARDs have failed multiple times. All of our biologics have failed. But you know, the rationale behind this is not unreasonable, meaning that there is a component of inflammation that drives, you know, early events in cartilage degeneration. That is one of the earliest steps in development of OA. These cytokines are often mediators of pain, you know, involved in pain signaling. So why not, you know? But again, this didn't work, and it was again disappointing. I'm not surprised. I would say still my go-to drug for osteoarthritis of the hand is acetaminophen and cohesive tape for problematic joints. I wrap up fingers and immobilize them, and then I give them maybe 2 milligrams of prednisone for as short a period as I can possibly get away with. Other than that, I don't have a lot. It's really disappointing. My next one is IL-16 and lupus nephritis. This was actually a presentation, a plenary session presentation done on the second day, presented by Andrea Fava from Boston. This is abstract 0936. This is a proteomic study where they looked at urinary proteomics as a way of looking at lupus activity or lupus disease correlates, making the point that, you know, what do we do to best assess lupus nephritis patients? We have biopsy, we have sampling issues with that. It's not always available. We have proteinuria, which actually can be somewhat helpful or it can be misleading. And the idea here is that in multiple studies that they did looking at cytokines in the kidney, they actually showed that IL-16 is like the second most common cytokine found in the kidney. So they actually took 30 lupus patients, over 110 urine samples. They did proteomic sampling on that to see what they could come up with. And they basically showed that lupus patients who have class 3 and class 4 proliferative glomerulonephritis have a strong correlation with high urinary IL-16 levels, that those levels do correlate with histologic activity scores, but not chronicity scores, and that those levels will go down as the patient clinically improves on therapy. That IL-16 level was independent of urinary proteinuria, and that was sort of another key feature. And then other studies that were adjunctive to this looked at IL-16 staining in the kidney in renal biopsies and showed there's a lot of IL-16, especially around the glomerulus, but even within the glomerulus. IL-16 is a CD4 ligand, but it actually has a lot of downstream effects that are, clearly would make it a good immunologic target or an immunologic activator, I guess, in this situation. So they showed that this was very predictive. It was easily obtained. At some point, I guess it could be easily obtained. Again, to me, I found it novel, and I thought it was a really well done study that covered all its bases, looking at many different markers. But they, again, what sort of stood out amongst all the others was the IL-16.
Yeah, it was definitely well done, and there's been a kind of a hint at looking at urinary biomarkers in lupus nephritis, which in some ways makes sense, of course, because you're downstream from the target organ, literally downstream from the target organ. And but you also wonder, because obviously proteinuria is part and parcel of the disease. So you have kind of a gamish of proteins. You have the tubular, the TAM horse proteins. You have proteins that are leaked out from patients who have any sort of membranous involvement with their lupus. But you also have potential biomarkers of disease activity. Um, that would just be absolutely outstanding to have something like that. I think in the clinic, um, you know what the biopsy is, and of course we teach the fellows to not just take the number like three, because three could be one proliferative glomerulus among 50 with a little bit, or it could be just barely a four with a bunch of crescents and a lot of chronicity. So we desperately need something as a biomarker. I think the especially the more therapies that we have available to us. Now with the positive data looking for belimumab, with the other CD20 targeted CD20 targeted therapies, not just rituximab, which didn't work, but obinutuzumab, which is much more efficient at depleting. So yeah, biomarker of lupus nephritis would be just outstanding. Plus, you could collect it remotely. You can literally mail it in, and you can have many, many sampling points. And you can't do a biopsy that often. And I think sometimes it's hard to get them done. They're expensive to get done. So this could be really a tremendous advance to not only the clinical care, but also of the research studies into lupus nephritis.
Absolutely.
So I'm going to go into psoriatic arthritis, or should we take the chats, Jack? Or
Yeah, there's a bunch of them.
well, Nancy Lane gives us a shout out. Keep the faith for OA treatments. Hopefully, we certainly need them for so many patients. My gosh.
Right. Let's see. Gary Botstein. Anecdotal abatacept treating CPI-induced myocarditis. New England Journal. Thank you, Gary from Atlanta. What else we got?
Is it now standard to add belimumab? I don't know that it's standard. I think some people still come into terms with that data. That data was presented by Rich. Did a great job presenting it. Presented it earlier at EULAR. Looked at some subset analyses here, which was the new part of the study, the belimumab study. I have to look to catch the number of that presentation. But it showed that it worked actually. If it had lesser effect, it seemed like it was in membranous, whereas in 3 and 4, it actually it looked very solid. And he promised in the presentation today that he would get back to us about some of the other analyses that they're doing on that data to really help refine. So I don't know that I would say it's a standard of care, because the effect size it was small, for sure, but it was absolutely clear. So to me, what I want to say is, well, within that, if you have an improvement with one therapy over another of 15-20%, that's small. But who are the people for whom it really makes a difference? I think that's what we need to see. They also looked at race in that one, and it looked there were smaller numbers, but it didn't look like there was a lack of effect among African American patients.
Right.
So not a standard of care, but I tell you, that data still surprised people.
It's encouraging data, but it's certainly far from Dr. Bazavaraju, who's here in Texas, and has taken care of one of my lupus nephritis patients and done a great job. She points out this, what's the standard? I think it's encouraging data. Can't be misconstrued as a standard right now. I think we still have to rely on the drugs that have been good for us so far. Mycophenolate, when necessary, the Euro Cytoxin protocol. That seems to work really well for a lot of patients. So, but it's very encouraging. I think they just have to follow up on it. And it was also very encouraging, or all the trials being done right now where lupus nephritis is the primary endpoint, as opposed to trying to get a global lupus indication. So,
yeah, that abstract number, by the way, Richie Fury's was 1441. It was kind of an update that's been published New England Journal just earlier this year, but The new parts are the sub-analyses according to the histopathology of the kidney, and also the analysis by the race. And it was interesting when he gave his presentation, someone asked about the cost benefit, because when you say when do you use the different therapies, well, it's the tolerability, it's the clinical effect, it's the cost. So all those things go into the equation.
Right.
So I'm going to go into psoriatic arthritis, and there was a late breaker, LO3. Phil Meese was the first author in this one. This was deucravacitinib, which is a molecule that we've seen studied in skin psoriasis, and it's one of the JAK inhibitors, but it's really much more of a TYK2 inhibitor. And if the immunology makes sense, which it doesn't always make sense, it's really easy to predict the past, and I think that's what we do with the immunology. That's why we know IL-1 isn't really important in RA, because blocking it doesn't work. But if you drew out psoriasis and psoriatic arthritis, you might say that those cytokines that use the JAK signaling molecules, that TYK2 might be a very useful target. And this is a relatively selective TYK2 inhibitor. And of course, the flip side of that is, are there going to be differences in safety? Is it going to be any different compared to the other JAK inhibitors? But of course, first they have to prove efficacy. So this is a study in PSA. Typical criteria, they looked at two different doses, 6 and 12, and they met the primary endpoint was the ACR 20 at week 16. And then they got that in 53% of the lower dose, 63% of the higher dose, compared to 32% of the placebo. They also saw impact in functional status and in quality of life. Actually, nice distinction in enthesitis as well. They didn't see a bunch in side effects. Now, of course, it's psoriatic arthritis, where the generally the patients are younger and generally fewer comorbid conditions. So they tend to do well with a lot of therapies. We need to see more. We want to see what the skin effect is, because that's one of the things that people had hoped was maybe this would have a better skin effect than the other JAK inhibitors. But it was a positive study, and I think that's intriguing, and we certainly look forward to more data on that.
So, Artie, you do follow the psoriasis literature, and you run the same circles as those skin dermatologists. What's the take on TYK2 inhibition in skin disease? I think they had like a big paper about this 2 years ago, and I know it's out there as far as the research. It's being further studied, but is this going to stack up against IL-17 and IL-23 and those other new modalities?
That's an interesting question, and the dermatologists they're giddy with success with the 17s and the 23 inhibitors. So as I like to say, they talk about the PASI 75, the PASI 90, the PASI 100, the PASI 120, where you get completely clear and your sister gets 20% clear. This is not that. This is not that level of response, but it's much higher than what has been seen previously with the JAK inhibitors. Remember, a couple of years back, tofacitinib went to the agency, and I think part of why they didn't get approved at that time was that the higher dose was definitely much better than the lower dose, and it wasn't in league with what the dermatologists were seeing. So I think the attitude was, well, why do we need this? Now they are super hot on JAK inhibitors, not only in psoriasis, but boy, you name it, and they're looking at JAK inhibitors for the therapy for a whole manner of immunologic skin diseases. And there's a lot of orphan diseases in dermatology that don't get a lot of study, hidradenitis, the bullous diseases, and there's a bunch of interest in JAK inhibitors. So I think they are pretty high on these. And I get we seem to be worrying more, at least as of now, about the tolerability issues and the VTE issues with JAK inhibitors. Dermatology is very high on them.
Yeah, and I think it's I think it's great that the TYKs are being developed, and we'll see what their range of efficacy is going to be. But it's it's going to get really crowded on that JAK inhibitor floor now that the TYKs are going to be in there, and filgotinib, after it sorts out its problems with the regulatory agencies, might be on the market as well. I want to move on to another difficult disease to treat, and that is systemic sclerosis. Dinesh Khanna had a podium presentation today about a novel compound called ziritaxestat. Ziritaxestat. The name of the study is the Novessa study. I have to get you the numbers on that. Don't have it right here, but it's the Novessa study. And this is a study using this new drug, which is an autotaxin inhibitor. The idea being that there are a few main pathways that can lead to skin fibrosis, but autotaxin is one of them, and as is IL-6. And those two are somewhat interrelated. So this makes for a fairly attractive target. And that's what ziritaxestat is supposed to do. They studied it in patients with early diffuse systemic sclerosis. I believe this is like an early phase 2 study. They enrolled 21 patients on ziritaxestat and 12 on the placebo. And the primary endpoint here was going to be the modified Rodman skin score. And the groups matched up really well. There was slightly higher skin thickening with modified Rodman of 27 in the ziritaxestat group, 22 in the placebo group. But after, I guess, 24 weeks, which is the primary endpoint, the study drug did much better than placebo, -8 versus -5. And that was significant at both week 16 and week 24. They have a biomarker that showed significance. So again, this is great in that it's phase 2, but phase 2, a lot of things look great in phase 2. Will it pan out in phase 3 is what we need, but they are going further with this investigation. So I think that's encouraging.
Yeah, but they used to say like the Cubs, but I guess you could say like the Mets now. The start of every season it looks promising. In spring training they are gonna win the World Series this year, and I think unfortunately scleroderma is sort of like that. Think back over the years, so many therapies that not only made sense if you look at the mechanism, you say, well, that's an interesting mechanism. That's something all that could work. Think back to relaxin from decades ago, where it worked in phase 2 and actually had a biomarker. It had increased bleeding because it increased menstrual bleeding because that was part of the mechanism of it. Failed dismally in phase 3. How many other therapies are there? I hate to be negative about scleroderma, but you have your hopes up so many times by so many therapies that should have worked. So is it the outcomes? We looked at EULAR. There was a study looking at skin ultrasound as perhaps a more objective way of looking at skin. We desperately need some therapies. There's some hints of positive. So, and of course, Dinesh, he spins a great tale, and you got to be a believer, and it makes sense. But I think we really do need to see the longer term data.
Right.
So my next one, I think, speaking of an unmet need, and I really liked seeing this because I think just over the past couple of weeks, I interestingly have had a few people with giant cell arteritis. One of them just refused to take steroids, which is an interesting patient
Wow.
discussion. And another one who took the steroids, but is just, he said his wife wanted him on the steroids because he cleaned the whole house by 5 a.m. Because he was so manic. But what do we have? Well, we have the IL-6 inhibitor, we have tocilizumab and presumably sarilumab, but this is a late breaker abstract L06 for mavrilimumab, which is a GM-CSF directed monoclonal antibody that have been studied and had some positive results in rheumatoid arthritis. This is in giant cell arteritis. And I think, as we were just talking about for scleroderma, there's a scientific rationale looking at histopathologic expression within the inflamed vessel wall in patients with giant cell arteritis that you could make a case that it could be effective. So this is a study, a 70 patient study with either new or recurrent giant cell arteritis. They had a fixed tapering plan for the corticosteroids, and of course, corticosteroids are the mainstay of therapy. But then it was mavrilimumab or placebo, randomized, and flare was the primary outcome. And what they found out that disease flare by week 26, which is the time period over which they were also doing the steroid taper, had 46.4% of placebo and 19% of mavrilimumab. Overall, the tolerability seemed to be pretty good. Sustained remission, this is 83.2% of mavrilimumab versus 50% of those on placebo. It was both new and recurrent patients. Tolerability seemed to be relatively good. Not a lot of AEs, not a lot of SAEs. Of course, these are people, by definition, they're older and they have a lot of stuff going on. So they're going to have some AEs no matter what you treat them with. But I think this was interesting and promising. And I literally just thought of it because in the clinic, we get steroids. We have the IL-6 inhibitor. I don't know about you, Jack. I'm not a methotrexate believer. I don't think methotrexate is a really viable option in giant cell arteritis. I don't think it works. I think we use it because we're rheumatologists and we use methotrexate for everything. So I was excited to see the possibility of these data.
Yeah, it's certainly in the holster and ready to use at all times. And I have used it, but not with a lot of great hope. The IL-6 inhibitor seems to work really well in GCA, problematic GCA, in the uncontrolled clinical trials that are out there. So that's certainly an option, but getting it approved, getting it paid for is going to be another issue. I do want to see more development. I mean, there's a lot of patients in this country and all around the world with GCA. So, and even more with PMR. But interestingly, as much as there's a great need here, there isn't a lot of people using the approved IL-6 inhibitor here. So I'm not sure what the reluctance is. Maybe like we're too married to methotrexate. We're also too married to continuing that steroid at 10 milligrams, 12 milligrams, 15 milligrams, as opposed to using a biologic. But I think this is a great study. And I mean, so good that, one of the faults of the study was one of the secondary endpoints was time to flare. And they really couldn't calculate it for the mavrilimumab group because they didn't really have any flares, which is like a great thing.
Yeah, it's a funny population because they're older people with by definition they're sick people. Like you're talking about the gout population before, and I think there's a reluctance. I think if you look hard enough, you could talk yourself out of a biologic that in somebody who's over 60 and has some other comorbid conditions. But in those populations, is methotrexate, is that going to be a go-to? And to me, I think if you use methotrexate, you want to use it, you're going to use it 25 milligrams a week or more, even if you're going to do steroid sparing with it. So I was excited to see the data. The anecdotal data, as I know it for the TNF inhibitors, has not been as great, even though I think the anecdotal data are very good in Takayasu's. I don't think the anecdotal data in giant cell are that good.
Yeah. So a few comments, but not much. JAK inhibitors in GCA given IL-6 effects, theoretical, but not studied well enough to even talk about it here. And there is a concern about GI perforation. It's a very low risk event with both tofacitinib and even IL-6 agents, JAK inhibitors and IL-6 inhibitors as well. So
yeah, I think the GI issue I think is everybody who's going to qualify for this study has degenerative disc disease. Everybody has diverticular disease because all humans do by the time they get old enough to get giant cell arteritis.
Right. All right. So my next one is the results of a afternoon session where it was sort of understanding autoinflammatory diseases, and Dan Kastner presented this sort of like, what to do with undifferentiated autoinflammatory. But, you almost really should watch this presentation because Dan Kastner gets very demonstrative in this thing. He's playing super sleuth and he's banging on the table, and it's a really, really good scientific story. And it's a story of VEXAS. VEXAS is a new, not Texas. VEXAS is a new syndrome V for vacuoles, E for E1 ubiquitin activating enzyme, X being X-linked, A autoinflammatory, and S for somatic mutations. The story goes he had a patient was with an autoinflammatory like presentation, and they did a bone marrow, and the pathologist of the NIH was going over the bone marrow and said, there's these very strange vacuoles in the cells within the marrow. And she said, I want to study this further, come back. And they came back 2 days later and she said, aha, there's 2 other patients. So I had to look up. I remember this happening before. You need to look up these people and see if they have the same problem. And sure enough, they did have the same kind of presentation. And sure enough, all 3 of them were found to have this UBA1 somatic mutation. It's an X-linked somatic mutation. So they did further investigation. Turns out some of those patients had relapsing polychondritis-like symptoms. They did further investigations, and they found out that in their center, they had 21 males. They investigated them. They all had this UBA1, all male, middle-aged, high fever, sweets-like rashes, neutrophilic-like lung involvement, chondritis, VTEs, macrocytic anemia. They had a lot of other diagnoses. Most of them, more than half of them, were relapsing polychondritis. A lot of them were sweets or myelodysplasia. A few were polyarteritis nodosa. But they were all ultimately unified by these by the UBA1 mutation and the other clinical features here. So this is a new syndrome. It's going to be a rare syndrome, but it is a nice sort of scientific whodunit that's got a happy ending, and a new syndrome being described.
I think the key to any new autoinflammatory syndrome is the acronym. You have to have a cool acronym, DIRA,
Deficiency of IL-1 receptor antagonist.
yeah, the whole all the autoinflammatory syndromes. But
There's a whole bunch of them. The other thing I want to really underscore here is that Kastner said, and they're famous for their autoinflammatory clinic. They got Raphael Goldbach-Mansky and a bunch of other people that are just fabulous there. They have about 3,000 patients they follow in their autoinflammatory clinic, but only 1,000 of those people have a firm genetic diagnosis. 2/3 of their audience, they're not so sure, but they're following them. They're treating them symptomatically. A lot of them are on biologics. They're doing a lot of sampling to see if, where they can find like syndromes amongst the 2,000 are unrecognized. So don't be, frustrated if you can't quite figure it out. I think genetic testing is a little bit more available. If you want to do genetic testing in what you think is an autoinflammatory periodic fever, go to invitae.com, invitae.com. The patient can pay $100. Now it's $250 cash and get like 77 genes tested for. And you don't have to be writing letters to medical directors to try to get, the FMF gene tested for. You can get all 77 done. So just think about that.
Yeah, and it gets so complicated because you have somatic mutations. These are not inherited diseases as of yet because they just started. And then also some of those are lineage dependent. So you have a somatic mutation only in myeloid cells,
Right.
which makes it incredibly hard. I mean, Dan, of course, it can do the deep sequencing that you need to find those mutations in different cell populations. But if you just looked broadly, like with the genetic test, they would show up normal. So maybe we're sending them over to Dan, and maybe Dan will name a disease after you.
No, there's already a Cushing syndrome. All right, we got about 10 minutes left. It's lightning round. Why don't you do a mulligan? Tell us about your research at the meeting.
Well, I have another one teed up, so I'm going to do that one.
Okay.
That's abstract 40, and this is a whole-blood RNA expression in clinically suspected arthralgia. And this is from the Netherlands, and of course, they do fantastic work there with the early arthritis clinics, including people who don't have inflammatory arthritis. Those who have arthralgias, maybe seropositive. Of course, they collect these folks and follow them. There's great information, including at this meeting, about the how likely are they to develop inflammatory arthritis, and shocking numbers. They're actually pretty low. Like if you're CCP negative, basically by 2 years, you're only 15% of you who have clinically suspect arthralgia are going to have inflammatory arthritis. If you're CCP positive, maybe that's 30, 40%. So this was from one of those clinics that contributed to several of the several of the abstracts of the meeting. This is abstract 40, and this looked at whole blood RNA expression. So again, transcriptomics, expressionomics, or proteomics, looking at the RNA level. And what they did is take a couple hundred patients from the Leiden clinically suspect arthralgia cohort, followed the patients up through 2 years or until they developed inflammatory arthritis, looked at 135 genes in innate and adaptive immune system, and said how can they detect who is going to develop inflammatory arthritis. So of the cohort of 230 or something, 20% developed inflammatory arthritis. And interestingly, of the 100, you think one of the problems when you look is multiple analyses, and you're going to find something. What they did find is that there were 6 genes that really stood out after controlling for multiple testing, which is what you have to do. If you're going to look at 1,000 variables, some of them are going to be significant. So they found 6: interferon gamma, PHEX, insulin-like growth factor 1, IL-17 receptor, CD19, and the chemokine receptor, CCR7. Looking at linkage, what they ended up with was that 2, IGF-1 and IL-17 receptor, were most differentially expressed in those people who went on to develop inflammatory arthritis. So the data, doesn't make sense necessarily because it doesn't fit with our little story of how people develop inflammatory arthritis. But the data were pretty clear. And of course, one of these biomarker studies, they always predict the past, and we need to predict the future. So I'd love to see something like this validated. But it was nice, crisp data that said that maybe we can find out that we go to clinic next week or this week, somebody whose joints ache and they're CCP positive, but they don't have arthritis, and maybe you get an ultrasound and they have a little power Doppler signal. What's going to happen to them, and how can we know? And if we did know, that gets the whole idea about early arthritis or early treatment of arthritis, which could be that much better than waiting longer.
The other abstract that sort of ties in with this is the one that you and I looked at, 481, which is about patients with suspicious synovitis, meaning that they don't have any swollen joints, they have a few tender joints, but they have an ultrasound signal for synovitis. And that was a fairly large 3 cohorts, like 200 or 300 people in each cohort. And they looked at, the predictors of developing rheumatoid arthritis. And the bottom line was fairly low level, just like you said. But if you were CCP positive, and it didn't tell us about high or low CCP, that your chance of developing RA went up from like less than 20% to almost 50% on average. And that's sort of what I think the practice is. But the question is, if you have an ache and a pain, but no swollen joints, but ultrasound synovitis, and you're CCP positive, should you be on a DMARD? The authors on that study said no. And I think that currently is the standard, but there are a lot of people that are being swayed into treating those people right now. And I think you can treat them symptomatically, but I'm not going to treat an MRI, and I'm not going to treat a lab, and I'm certainly not going to treat a little power Doppler signal. I think you really have to treat swollen joints at this point.
Yeah, absolutely. And you'd overtreat a lot of people, which is, I think that gets to the idea, what are you going to treat them with? I think everybody thinks Plaquenil is pretty safe, but that's not super effective. So what do you treat them with?
Yeah. I got a quickie. My 1607. This was done by one of the fellows from Dr. Chang from UC Irvine, and this was a retrospective study of their clinics and looked at those gout patients who received dietary counseling. That was like 30 patients compared to the gout patients that did not receive any dietary counseling. And they showed, when they followed them out 2 years, that the people who received dietary counseling, they achieved target more frequently. And that was both at 6 months and at 2 years. They had less flares overall. This is something we talk a little bit about. First off, diet, is it important or not? I got yelled at in Boston when I said, not so much in my clinic, but they said, oh my God, shellfish up here is a gigantic problem. So I learned something in my trip to Boston. But, I don't think we spend any time doing this. And this, to me, says we probably should spend a lot more time counseling people on diet.
Yeah, and if it could have a benefit, I mean, I think that's part of the excitement for the studies on the microbiome, and absolutely there's an answer, and I tell people there's an answer. I just don't know what it is. Should you eat nothing but yogurt? Should you avoid all yogurt? Should you, I think there are some things that you can tell them, and maybe we should be trying to tell them a little bit more. But it's hard to say that we know what we're doing when we're telling them to manipulate their diet outside of some conditions. For gout, yeah.
Yeah. All right. What's your next?
The last one I think I'll do is the number 507. So this is an analysis of the EXCEED study. Remember, the EXCEED study was in psoriatic arthritis, and it was secukinumab head-to-head with adalimumab, and they both did very well. In fact, the secukinumab very respectable responses, almost made it to be better than the adalimumab in the joints, and did make it to be better in the skin. This looked at the sex response, and what they found is that overall, the female patients with PSA, and remember in PSA studies, it's about half and half. That it's not ankylosing spondylitis where it's mostly men, or rheumatoid arthritis where it's mostly women. It's evenly distributed, but they had greater baseline disease severity, and they did a little bit differently than the men did. So we tend not to think of sex in the outcomes, I think, as we think of studies.
Wait, wait,
Because
wait,
some
wait.
of
You're telling me that sex was an outcome in this study?
that sex affects the outcomes. I don't think
Oh,
we don't pay much attention to it. Um,
so
the men tended to have higher responses across the board for skin, and really remarkably for the higher levels of response. So I think there is, there's definitely differences between men and women. I don't know if we've talked about that, Jack, but you can measure the various aspects of the immune system are different, and yet we lump them together. We say, you got this disease, you got this disease, you got 10 joints, so does he, you're the same, and that may not be.
yeah, the disparities by sex are kind of a big theme at this meeting, especially a lot on spondyloarthritis as well. The playing on the theme that women tend to be diagnosed later and yet have more severe disease and more pain and whatnot. So yeah, that's surprising. I was not aware of this particular abstract. My last one is going to be a quick mention of Michelle Petrie's three abstracts, 1261, 1262, and 1266. They all deal with the issue of testing for antiphospholipid syndrome. As you know, she runs a fairly large lupus cohort at the Hopkins Lupus Clinic. I think they have 800 patients. They had a total of about 88 thrombotic events in their clinic, both arterial and venous. And in her testing, she shows that the one that is hands down the best test and outperforms all the other tests, even combined, is lupus anticoagulant. The patients who have lupus anticoagulant outperforms either the antiphospholipid, any of the subtypes, or being double or triple positive. She showed the lupus anticoagulant. If you have that, you have a threefold higher risk of arterial thromboses and a fivefold higher risk of venous thromboses. And of course, these thrombotic events tend to be multifactorial. There's a lot of other things that are in play in these lupus patients that add to it. But then you fold that into the other story that she had in abstract 1266, comparing MI and stroke events in their lupus cohort. That turns out that you get stroke real early in lupus, but MI not so much. That stroke and all of its forms was related to lupus activity by complement and also to lupus anticoagulant, where the same could not be said for MI. The risk of MI and lupus in her cohort seemed to be very multifactorial and very time dependent. So why that is, she found curious, and she basically throws that out for anyone to consider that wants to research this, but it's obviously something that she's concerned about.
Yeah, and I think we sort of had that as one of the things that we had learned, I thought, over the years, that lupus anticoagulant was the strongest correlator. Of course, that test which one you're using. Is it the hexagonal phospholipid? Is it the dilute Russell Viper venom? Do they perform the same? And I
NT.
know when this comes up in the clinic, nothing I hate more than an uninterpretable result on the test where it's like, it should be yes or no. You should correct the with the dilute Russell Viper venom should correct, or it shouldn't. And then sometimes it's like, well, it kind of corrected, and then you don't get an answer with that.
All right, that brings us top of the hour. We want to thank everyone for tuning in to Rheumatology Roundup. That's it for this year. We hope to see you in 2021 in San Francisco, or again at the dining room table, wherever it's going to be. But maybe we'll just have Artie. You have a Facebook chat room that people can go to.
I've heard of the Book of Face, but I have not yet partaken.
Oh, okay. Well, that's another. We can talk about both sex and Facebook after we close this meeting. Thank you very much, everyone. Have a good night.